why don't the ROI models align with my actual total cost of care? I see ROI models of 30% from lots of different sources, health plans, point solutions, and everything in between, health systems, hospitals. And yet I still see a rising total cost of care. And how do we understand that? And frankly, not something that we just complain about, but how do we actually build a strategy about that and have a foundational benefit strategy at Crossover? And of course, hopefully there'll be some ideas for your own companies. So with that, I want to introduce our panelists, and I'll hear their bios, but I want to start by introducing Dr. Stephen Ezeji-Okoye. Stephen, do you want to take a second and tell us about yourself?
Thanks, Nate. As Nate says, I'm Stephen Ezeji-Okoye. I'm Crossover's Chief Medical Officer. I've been with Crossover for about 4.5 years. I'm a primary care internist by background, and prior to joining Crossover, I worked for the Department of Veterans Affairs, very much interested in how we improve the overall health of populations and how we make systems more efficient.
Excellent. Thanks, Stephen. And then Jim?
Nate, thank you. I appreciate the opportunity to be on the panel and hear this conversation, participate in the conversation today. I'm Jim Huffman. I've spent my career in employee benefits. Today, I'm with a consulting firm, Alliant Insurance Services. Prior to that, I was managing corporate benefit programs for the last 20 years in big companies, working with some industry groups as well, Business Group on Health and ERIC, and really have a passion for ensuring that we're working on the healthcare of our workforce and covered members.
Great, thanks, Jim. And Patrick?
Yeah, Patrick Curran. I am an actuary with Optum's Provider Actuarial Services practice. We work with primarily with providers that are taking on risk or bringing innovation to the healthcare system to help them navigate and especially find new ways to quantify and get paid for what they do. I'm very excited to join this panel and this conversation, as my prior life also includes working with employee benefits consulting and helping employers design their plans and evaluate programs such as we're going to talk about.
Awesome. Thanks, guys. And I'm going to stop sharing just so everyone can see our faces a little bit better. But so I want to start this discussion out with this question. And I really asked this question from wearing my hat, being on our benefits committee and thinking about the set of services and the value proposition of those services and the stated ROI of those services for Crossover employees. And the thing I constantly find myself in as I hear the sales pitches is just what that ROI is if I implement this solution, which might be bigger. There's point solutions that might be smaller, and I'm stacking up all of these ROIs, and I feel like at the end of that stacking process, I feel like I should be getting money back. Like people should be paying me if I actually added up all these numbers. And there's a really funny character out there in the healthcare world that I think does good. His name's Al Lewis. He's written some books. He's a blogger, and he gets very skeptical of these ROIs. But Patrick, as I think about me on the benefits committee at Crossover, how should I think about these ROIs? I see lots of different sets of information. I see oftentimes 30% ROI. I see statements like they're risk adjusted or claims based or propensity matched, and it's kind of an alphabet soup of jargon. And I'm not always sure how to process that information as I'm evaluating these ROIs, these different programs. So kind of from your perspective, how should I think about that? And what are some of the strengths and weaknesses that you see in ROI models that are out there?
Yeah, I mean, ROI, return on investment, it carries a lot of connotation with it, but it's important to recognize that in the marketing sense, especially, this is not an accounting exercise. These are prospective models with a high degree of uncertainty. So they should certainly be considered directional, not guaranteed. When I look at these, I mean, I kind of go through three major steps. The first is look at the methodology. Is it sound? Do I have access to a range of estimates versus simple point estimates? Then I start thinking about the scope and the timing. Who does this ROI that's being quoted to me apply to? What segment of my population is it applicable to? And what is the timing of this return? Will it happen on my annual benefit cycle, or will it be longer? Do I need to consider turnover? Are these employees going to be with me any longer by the time they realize the return, et cetera? And then the last thing is sort of a catch-all, is what's the overlap with other programs that I have out there, and how complex is this model? Is it sensitive to external factors? COVID is the really easy example to think about. Is a lot of these care intervention models would show great return on investment for all the foregone care during COVID, but was that really a function of the intervention or the program that you're putting in place? So understanding how complex the modeling is and how uncertain that can make it with external factors is important. It doesn't invalidate necessarily the ROI that you're seeing, but it helps translate it from being a black box to understanding a little bit of what goes in there and what's a realistic expectation rather than a simple 30% point estimate, and knowing that you can't necessarily take that to the bank.
Yeah, it almost seems like from what you're saying is that the ROIs that we see, you really have to ask yourselves these follow-up questions about directional versus guaranteed, what population it applies to, the timing of those returns, the employee tenure, right? Like you could be implementing a program and then employees are cycling off every 12, 18, 24 months, and you're just not going to realize that. And then, what's the overlap? I think that's something that we see that I've always been confused with is everybody has a 30% ROI, but we're talking about the same population. Are they all achieving? Are they taking credit where credit isn't due? Who should actually be getting the credit? These are some of the things that I think about when trying to contemplate, well, am I really going to get that at crossover, that ROI from this vendor? Jim, you've been around a long time, from the consultant hat, from the business group on health hat, from the employer hat. What are your thoughts on the ROIs that you've seen?
Well, a lot of the points that Patrick mentioned are spot on with what I've experienced, Nate. I think, the employees turn over. I mean, we've seen employees throughout my career. Nobody stays with an organization forever. So as you have that churn and new people coming in and people leaving, who does this program apply to? And as you just mentioned, are you going to see that return that they've committed to you or promised to you in that time frame that you're looking for? And is it on the plan year? Is it over multiple plan years? How is it going to pay back? So I think that adds a whole complicating factor to it. The other is who's doing the calculation, right? Is it the vendor? Is it a third party that we're mutually going to pay for? Or am I going to pay a third party to do that as a plan sponsor? And then how much time and effort is it going to take for us actually to get into the details and validate that? I've seen some scenarios where everybody wants to let the claims run out, and now you're talking 12, perhaps even 18 months out from when that window closes on the measurement period to really get a good snapshot. And at that point, I've already run 2 enrollment cycles. I'm probably setting the pricing for the next year, and I'm looking back perhaps 24 months to figure out, did the program work? So I think that's a whole complicating factor around what we call ROI.
Yeah, great point. Stephen, what are your thoughts?
Yeah, I think one of the key issues is really who does the intervention apply to? And because often when these ROI calculations are done, you're really looking at a very select population. It's the population that completed the intervention or was highly engaged in intervention. It's not necessarily even looking at everyone who touched the intervention. And so you're seeing a highly select sample that's being measured on the ROI. And one of the big questions, I think, is both Jim and Patrick mentioned, is does that actually map to your population at all? And what would the effect be on the whole population? For example, if an intervention is really targeted for something like severe panic disorder, well, that's 0.5% of the population. And how much effect is that really going to have on your total ROI? And of those people who have that disorder, how many are going to be offered that intervention? How many are going to complete that intervention? So I think you really have to take a very holistic view of what's being presented to you and understand how that applies to your particular situation, particular population, because, as they say, results may vary.
I think that's a great point. That's probably a struggle, Patrick, with some of the work that you do when you're actually doing a true ROI on a population. That do you have the sample size that makes the results credible, right? Because
For sure.
You're talking about, panic disorder, Stephen. That's a very small population. It might be a struggle to even get a credible population to work with.
Yeah, and even more, you could extrapolate that to even more common conditions. So diabetes is always a common one, and you'll see studies that a particular intervention related to diabetes will save X per patient. But as you dig in, is well, what is the incidence rate of diabetes for my population versus the general population? And is the study based off of Medicare fee-for-service data, where a lot of these people are probably older and unmanaged, and maybe it's risk adjusted, but most of the risk adjustment models aren't designed to normalize for all those social determinants of health as well. So is my population truly as unmanaged as the study population that the return's being quoted to me on? And a lot of these that require collaboration, but also expertise to dig in and understand truly how many people within my population is this going to apply to, and do they have the same profile? Should they expect the same results as whatever the study population was that the ROI is quoted on?
Yeah.
Another thing is the study an intention to treat analysis, so that you're looking not just the people that completed the intervention, but everyone who was offered or engaged in the intervention. Because in the example that Patrick was giving, if you have a program that's really effective for people who have diabetes, but only 1 in 10 can actually complete the program, that's a very different analysis if you look at the effect when you compare it across all 10 as opposed to the one that got through. And I think that's something that is often not included, and makes the results look much better than what they truly are.
So I think these are all good points, and it leads me to say, hey, look, looking at these marketing documents that have these stated ROIs may not be the best strategy to move forward with, but you still have to move forward with the program. Jim, I mean, you've been in the shoes, like you're expected to deliver a strategy. And so, how, I kind of want to understand from your perspective, like, how do you move forward building a strategy when you've got to be a little bit critical of some of the ROIs that you see, and yet you got to deliver a value-based program to your employee population that helps them achieve some health, right? So what's your approach in doing that, Jim?
Well, I honestly, Nate, I would set those ROI commitments to the side, put them in the parking lot, and just hold them for now. I think one strategy that the teams that I've worked with over the years, we've really kind of embraced is, what are the opportunities that exist in the workforce and in the claims data? So beyond the workforce, the covered members that are in the plan, and let's take musculoskeletal. Over the last few years, it's really taken off with multiple point solutions. Everybody's got 1 or 2 different musculoskeletal solutions now. But I think many companies are now asking the question: is it working? Is it delivering the value and the impact that I hoped it would, or that the vendor told me that it would? And we would tend to look at not the ROI, because that's so challenging to measure, but really what was the situation we were dealing with. If we were seeing in our claim data lots of lower back surgery, with lots of people missing work because they were now on short-term disability or long-term disability during their recovery, or rehab or pain meds, that total cost of care that you teed up at the beginning of our conversation today, look at that, and have we had an impact on it? And then you contrast that with some of the solutions that are out there in the market right now, center of excellence, surgical center of excellence, where we're asked as plan sponsors to send people to these regional locations where either they've demonstrated impact, the ability to do it in a cost-efficient way with good outcomes, or they're simply just offering bundled prices and really no quality around that or effectiveness around that. How do we ensure that we're getting the right people into that surgical situation? And then when surgery does happen, it's at an effective price, a good price, but more importantly, the individual's back to some level of productivity, whether it's the employee or the family member, they're getting back to some level of normal activity. That's where we look at what I'll call the value on the investment, not the return on the investment, but the value, because that's going to be a little bit more challenging to measure. And I'm not going to hold necessarily the vendor accountable for that, because it is far broader than what they can control and they can impact. But it's something that I, as that benefits manager, need to look at, and I need to be accountable.
Jim, in some of those situations, do you see that costs the plan more money? Do you worry about that? Do you, I think that there's different, you may send somebody to a center of excellence that's a lot more money, right? Than kind of a procedure locally in your community. How do you kind of balance that?
Yeah, so the short answer is yes, your cost could increase in the short term. But let me take it out of the surgery scenario for a second. I'll give you a different example of one that we've often used as prescription medication. I have said to my PBMs over the years, I'm okay with my near-term cost going up on prescription meds if it is for those people who should be taking their medications and it's going to save the plan money in the long term, right? And we've talked about hypertension in the past and how that is a very low-cost medication today, pennies a day for someone to take an antihypertensive. If they do, and Stephen can give the probably more accurate clinical picture here, but we are mitigating the risk to a certain degree, all things considered, of them having a coronary event or a stroke later in life. So I would much rather see all of my hypertensives and pre-hypertensives being managed, and if it's medically, then that's great, prescriptions, versus not taking that, me holding my prescription trend line down, but then I'm going to pay for a whole bunch of strokes in 5 or 10 years. So it's an investment. We have to invest some of these dollars today in more of a preventive and taking care of things before they become bigger, right? The other scenario that I'm sure everyone's familiar with now is when throughout the pandemic and cancer screenings were not happening. Now we're coming out of it, and employers are seeing more cases at stage 3, stage 4. More expensive, more of an impact on that individual and their family and the workplace. So how do we get back to more of a prevention, spend now, and maybe spend a little bit more now so that we save in the future?
Gotcha. And let me just for the people that are joining this webinar, we do have a Q&A box at the bottom. Feel free to submit some questions there, and I'll capture those and ask them to our panelists. So I like what Jim just said, Stephen. His perspective is like, hey, you gotta have to take the marketing ROIs and set them aside and look at your claims data and look at the problems to solve and build strategies to get to value around those problems. So Stephen, you worked in the VA system. You've seen a broad demographic of patients over the years. What are some of the core elements of value that you would suggest to an employer where they spend time and invest or research areas that might have an impact on their populations?
I think Jim's focus is on moving to prevention is really the right one, because I think one of the challenges that if you're just working in the area of disease management, there's only so much more efficient that you can get. And does that efficiency really translate into not just cost savings, but actually good outcome? And, for example, if you send someone to a center of excellence that is really good at amputating feet off of people with diabetic foot ulcers, yes, you might save money, and that you could chalk that up as a value-based win. But is that really the outcome that anybody wants? Would we be better off spending the money trying to make sure people didn't get a foot ulcer to begin with, or even better, trying to prevent them from having diabetes? And so I think the focus has really got to start where we're looking at from a prevention arm. And I think the data shows that places that and countries that invest heavily in primary care live longer and are healthier and spend less. And I think that really should be the focus of how you're putting together your benefits program, because you want to make sure that you're doing the prevention, and you want to make sure that if people do have chronic diseases, that they're being managed. And you want to make sure that your providers actually have the time to make sure it's the right care at the right time in the right place. I mean, Jim raised a great point. Things like treating hypertension now is going to save, cardiovascular complications down the line. And it's a much cheaper and easier thing than, standing up a center of excellence for a cath lab or a cardiac surgery program. The other thing is that you want to give time into primary care, because in primary care, if you're rushed, what it results in, you order intervention, you order medication, you order imaging, you refer to a consultant, all ways to buy time that add money but don't necessarily add value. And one of the big things, you mentioned my experience at the VA, one of the big things that I noticed is that it's very easy for providers to start medications. It's much harder for them to stop medications, because they don't necessarily understand what was the logic behind why this medication got started. And so you can get into issues of polypharmacy, which cause problems that then result in more medications or more interventions. But if you really have a comprehensive primary care program, it allows you to actually then strip out care that's unnecessary, that actually may be harmful, that's driving poor care, as well as allowing you to bring together the member and the provider to have a really good understanding of what's important to that member and what's going to mean health to them. And I think that can really help you design what are those interventions that are best in your employer benefits program, as well as what are the best interventions to have in the healthcare community.
It's funny, Stephen, I think one of the greatest drivers of cost in healthcare is just the lack of connectivity and the longitudinal relationships with your providers. They just don't exist. And so, some of the areas of value that I always think about is unnecessary care, right? You talked about that, saying, hey, look, you're doing imaging, you're sending out to a specialist to buy time, and it doesn't really result in a better value. So it's that lack of connectivity to your providers, where you have a longitudinal relationship that, they can make sure that you're not on a dozen medications, and the medications that you are effective and are working for you. I think we're also at a really struggling time. And Patrick, I'm curious from your perspective in terms of the areas of value, where do we invest in value and hope to have impact? I mean, I know that everybody's probably wrestling with the GLP-1 topic. And as I've looked at the GLP-1 for a crossover, the thing that I think about is like, this is the first wave of these types of medications. Like, there is a drug pipeline of a lot of medications that are expensive, like these GLP-1s, that we're going to have to make proactive decisions about. Otherwise, our healthcare costs are just going to go through the roof. And so, Patrick, from your perspective, what are some of the other things that you're seeing in claims data or costs that are coming up where employers need to be more proactive to stay ahead and make sure they're providing value to their members?
Yeah, so I mean, pharmacy has always and will probably be number one on that list for a long time. Specialty pharmacy, whether that be provided through retail or provided within the doctor's office, very powerful, life-changing, finance saving interventions in those cases, but but also very expensive. So ensuring that those are making it to the right people is always one of the kind of number one concerns there. You don't want to withhold those treatments, but ensuring that they're controlled and provided appropriately. But they're also being used to treat these conditions that have such a long tail. Even going back to like the hypertension example, well-managed hypertension is gonna prevent acute complications much further down the road. The disjoint kind of nature of our healthcare system and the different stakeholders, different payers at different points in people's lives, your well-managed hypertension might be saving Medicare money versus your employer plan. So keeping in mind kind of that timing, how some of those pharmacy interventions, the drugs that are out there are also going to overlap with the returns you might be expecting on your wellness programs or your MSK solutions and all of that, and ensuring that you aren't double counting as you stack, and you're really translating the ROI quotes that you have a measurement strategy to truly calculate what the value of those interventions are to drive your strategy long term.
Yeah, one of the things that I get really nervous about is, I read all the headlines about the hospital systems during the pandemic really being squeezed because a lot of the procedures that take place there that keep them alive. Jim, I think you mentioned it with the cancer screenings going down. Hospitals really struggled, right? And now we're coming out of the pandemic, and I think there's just going to be some expense that we're going to see on those increases. And, I think there's usually, 3-year contracts, and then the rates go up. And that's the one thing as an employer, I have no control of that. Once my member enters the hospital, I'm just paying the bill however it comes at me. I might get a better negotiated rate, but there's nothing that prevents anyone from doing more imaging. Maybe the unit cost is a little lower, but doing more imaging or any of those things. And so that's one of the areas that concerns me. I don't want to be pessimistic on this because I think that there's opportunities and you have to move forward. And I want to start with that. And there's a great question that came in from the audience. And I want to frame this up asking about, hey, what are the best health behaviors that drive long-term value? And Stephen, I want to start with you. Let's say that you're a doctor, right? If you kind of set aside all the traditional things we know about benefits, about insurance, about the way that we consume healthcare today, from your perspective as a physician, and you wanted to design something that was going to have great impact in the lives of your members, how would you design healthcare delivery or the way they consume services that might be a different approach?
Yeah, so that's actually one of the reasons I came to Crossovers, because at the VA, I felt we had a good approach, but the problem was our average age was 65, and the interventions we were trying were on people who already had established a lot of chronic diseases, and you really need to engage people early. And I also felt, I wouldn't say disillusioned, but I felt that the medical system promises too much and underdelivers. So in essence, the feeling is,
what do you mean by that? What do you mean by that?
What I mean is that it doesn't matter what you do. We have a pill or intervention that will fix you or make you better. And the reality is that's not what happens. So I often have described primary care as a management decline because we meet people and have long relationships with them. And when we meet them, generally that is the healthiest they're going to be. And they are on a journey, a health journey. And the question is, how are we going to influence that health journey in terms of making sure that they're as healthy as possible to the end of their lives, or will their health deteriorate and shorten their lives? And are the interventions we have going to help that or not? And so when you actually look at what has made the biggest difference in longevity in the United States, it's really been population health interventions. It's sanitation, it's vaccinations. Things like the medical interventions have only made a small extension life expectancy. And most recently, we've actually seen a drop in life expectancy around things like the opioid epidemic. And I think what it really points out is that a lot of the factors that drive our health have more to do with our behaviors and our environment than actually the medical interventions. And when you look at what makes us healthy, about 80% of it is related to socioeconomic factors and our behaviors. Only about 10 to 20% of it is really tied to medical interventions. And so, one of the things that I realized is that the biggest thing I could do as a provider is be able to talk to someone about their risks, about their behaviors, help them make sure that they're doing their preventions, they're managing their chronic diseases. But really the thing that's going to make the biggest difference are the issues around self-care. So where you live, if you live near a freeway, because of the air pollution, the noise, and the attendant stress with it, you're not going to be as healthy as someone who lives in a much more, much closer to green space. If you smoke, if you don't manage your weight, you don't exercise, those are going to have a much bigger impact on your overall health. And so I view the very first thing that we should be doing in healthcare is really promoting those behaviors that support good health and discouraging those behaviors that will lead to worse health. We have to stop looking for a technological solution to a societal problem. And I think that's a place where both healthcare can do more, and where also I think employers and patients, frankly, should be asking for more.
Stephen, I hear that. Of course, I work at Crossover where we do primary care. That's such a non-sexy response, It's like, and I think it goes along with our disposition in the United States. It's like your point of like, we can do whatever we want and then take a pill and it will be fixed. I think, societally, that is a real challenge that we have to deal with. Are we going to fix that, right? And how
when you look at lung cancer death rate, the biggest thing that has driven the lung cancer death rate is not chemotherapy, it's not surgery, it's a societal change in the way that we viewed smoking. I think it relates directly back to what you talked about with the GLP-1s. The GLP-1s are terrific drugs that work super well. But in 1970, 10% of the population was obese. In 2020, it's 40%. What's changed in that period of time? Our jobs are more sedentary. There's an explosion of highly caloric, low nutritious foods. There's a whole host of things which has driven that. And I don't think that a medical intervention is going to solve that problem. It's going to cost a lot of money, and it may help certain individuals, but we have to have a societal shift, much like we did with tobacco, if we're really going to see interventions. And you're right, it's not sexy. I mean, people would love to have, it would be great if we had a pill or a shot that fixed everything. But unfortunately, that's just not the way. That's not the way the world works. There's no free lunch. I would say that these interventions may bring you back to the line you were on before in terms of your decline. They don't improve the line you're on. Whereas exercising, managing your weight can actually improve your line and improve your longevity and also the quality of life, not just the quantity of life.
Jim, let me go to you. Okay. Again, this is unscripted, so I'm going to put you on the spot and appreciate your opinion. But what Stephen's talking about is hard. It's hard to implement in a strategy with benefits, right? Where you're making access and coverage available to members, but how do you get to that lifestyle component? Like, how does that become relevant, right? I just think about one of my concerns is that I'm a little pessimistic on PPO plans and whether that wide open access is gonna be able to, create value for my employees. And ultimately, if you do anything to restrict access, I mean, it is alarms going off everywhere. You can't do that, even though some of that will be valuable. How do you start to implement with success some of these things that Stephen was talking about?
Well, first, I want to nominate Stephen for Secretary HHS. Let's get him at the national level where he can
Got a
start to
job,
address
Jim.
things.
He's got a job. That's
Well,
not, he's got a
It can
job.
be part-time job. He can work on
Part-time.
it on the side. It is not easy, Nate. You're right. But I think, as I was listening to Stephen and some of those great examples, it's cultural. So within the confines of an employer-employee relationship and employer-sponsored insurance, I think it has to go beyond just the PPO network and restricted networks and centers of excellence. It's got to get down to that, I hate to say, but a culture of health. And so is the company promoting, encouraging, and removing the friction that exists so that people can focus on the culture of health? And you've seen lots of studies where employers have done things with their cafeterias. Whether you remove subsidies on sugar based drinks, or you give away the free salad bar, there are lots of steps that organizations have taken which are going to help create an environment, an ecosystem where the right choice is the easy choice, or in some cases, the only choice. But I think you have to start there. And I think it has to be that cultural change and that cultural environment that people are operating in every day that is the starting point. Then you can get to some of the things like plan design and network options, and whether you have steerage based into your plan or not. But I've shared this with my primary care doc, and I'm at the point in my life where my primary doc is reminding me about a lot of the screenings that I have to do, and I do need to watch what I eat and how much I exercise. And I've basically said, I love potato chips. I'm not going to give up potato chips. What else can I do? And we kind of take my patient perspective into that conversation around, okay, well, here are the trade-offs you can make. Instead of going into the office visit and hearing you've got to stop the salty foods, let's figure out something that's a little bit more realistic that works for me and my health, but gives into some of my cravings. And I think that cultural piece and the flexibility with the patient in mind and the patient perspective is the starting point.
Yeah. I think that's an excellent point of having that culture of health shift, which, to be honest with you, is extremely difficult. It's a long-term strategy, and you got to believe in it as a company, and that's tremendously difficult.
There's one more thing there, because I don't think I hit this hard enough, but the environment. So removing the friction is really important, and I think we all learned a really valuable lesson through the pandemic of the willingness and the convenience of virtual care and being able to engage in a non-face-to-face or non-traditional way. I'm not suggesting we're going to stay there forever. In fact, I think we've seen the stats indicate that we're moving back away from the virtual. But how do we remove friction so that individuals can get to physicians, care teams, when it's convenient for them? Because if we continue to say it's 9 to 4, Monday through Thursday, and the office closes at noon on Friday, people are not going to engage. And that's the wrong direction.
Yeah, I think that's a huge point. I think so much of it is about how can you improve access? Because, people go to ERs and urgent cares because they're convenient and they may be quicker and easier to get into than their primary care provider. And so if we can actually make better options, then it allows us to engage into a longitudinal relationship rather than a fragmented relationship, which may only see a piece and is addressing a specific problem. And, I think once you have that relationship, it allows you to be able to do things which are to look just beyond the biomedical model. And I think really, my initial comments were really more to say that if we're going to tackle disease, we have to look beyond just the biomedical aspect. The biomedical aspect is critically important, but it's not the only piece. We've got to be able to make the shift to the looking at the psychological, the social factors that affect health. And in that way, begin to change the culture so that we're not just looking, for the pill, or, not everything as a fractured arm or a UTI that responds easily to something. But we really got to look at the whole person and all those things that really drive the health and well-being.
Let me just, there's a question that came in that's great, and I think it really lends talking about, Stephen, some of the things that you talked about, focus on prevention, Jim, the culture of health. but how do you pay for healthcare like this, you know? And I think this really lends itself to getting away from the transactional things that both of you are talking about, you know, Jim, where you're actually able to like have that relationship with your provider. But, you know, for those on listening to this, I think you really have to understand the damage that fee-for-service does. I mean, this isn't a desire for providers to get out of medical school and go practice in fee-for-service, which compels them to see lots of patients. I mean, in order to like be able to afford a salary and a staff and an office and those types of things, you just have, in the fee-for-service model, you have to see lots of patients. And when the providers, when the system is running like that, even if a person wants a relationship, it's not going to happen because the machine that is really running healthcare, the healthcare system, is a transactional machine. And so trying to find ways where you can put providers in situations where it's a fixed fee or it's a financial arrangement where they're not trying to see 30 patients a day, but they're actually trying to build those longitudinal relationships. You know, I have through Crossover, I have a doctor, and it's been, I think it's been 2.5 years now. The best doctor relationship I've ever had in my life. And I text him all the time. We talk about life. We talk about my high blood pressure, tick bites that I thought, you know, but I can talk to him about anything, and it's not transactional. And it starts to put me in the mindset of like, if I have anything that comes up, lifestyle questions, I'm not going to Google. I'm going to John Abano. And he's a fantastic partner for me. But the reason that John can operate like that is because he is not trying to build those fee-for-service. I think that's a real danger. And so, you know, as I think about as we convert these from ROI focused, okay, what are the values we're going to focus on? Then how do we put those values in a benefit strategy? I think looking about how you're paying for healthcare and transitioning where you can from transactional to fixed fee might be a really effective strategy for you to achieve your goals. You know, Patrick, I want to put you on the spot like I like to put everybody else. Is there a way to think about that? Are you seeing more of those fixed fee models come about where employers can engage directly and it's easier? I know what's easy today is just to enter in a PPO and pay fee for service to your TPA or your health plan ASO. So are there ways for employers to engage directly and get more value through fixed fee models?
Yeah, there certainly are. Whether it be, so it's harder to come by provider groups willing to take that approach in certain parts of the country, depending on where you're located, because they're not always capitalized to take on that risk. But so much of what was described as the next level to truly influence change is nowhere to be found in claims or in the traditional healthcare system. And as you mentioned, the providers are not being paid for that unless they are in some sort of risk deal that would do this. So it's becoming increasingly prevalent. There's an added factor that employers have the advantage of is the population's aging. And for hospitals, commercial patients are getting older and they're becoming Medicare patients, and all of a sudden they're paying me, the hospital, half or a third of what I used to get when they were on your employer benefit plan. So more and more hospitals and health systems and multi-provider groups are willing to engage in new ways to get paid on the commercial population in order to secure that volume. It's their new way of securing those visits. Is they want the attributed patient. They don't necessarily want the visit anymore, because the pressure to get the per patient visits down is there and the population is shrinking. So they need to capture the person holistically through some sort of attribution model. And as a result, those are becoming increasingly prevalent on the commercial side of things.
Great, thanks. You know, I promised to keep this about 45 minutes and we're just a little bit over time, but I kind of want to summarize real quick and then ask you guys to close out with a thought that you might have. But you know, as we started, we talked about the stacking of the 30% ROIs that exist out there, and you know, Patrick helped us understand that maybe we should be skeptical / you know, ask the right questions to make sure that we understand the impact of those ROIs. Because I mean, certainly there's going to be ROIs out there. We want to understand if we take that and apply it to our population, will we get value from that? And that really led us down the pathway, Jim, of you kind of talking from your perspective of like, hey, I'm trying to look at where I want to get value from or what I need to get value from, and focus on those specific strategies. In some cases, it might cost us more money, but in the long term, it's going to create that value. And then ultimately, Stephen, I think the thing I heard from you is to not just focus on, you know, the biomedical results, but actually the psychosocial results as well, that the societal things, which are hard, and how do we get there? And so, look, as I appreciate this and listening to you guys, you know, this is definitely hard, right? This is hard work and requires us to think differently about it. But it's definitely a rewarding cause to be involved with as we think about the impact of our employees at each of our companies, right? And their families' lives. And so again, this is the grind that we need to be involved in, and continue to think about how do we adjust healthcare to deliver more value to our employee populations. You know, I'd love to hear from you guys. That's kind of my summary, but love to hear Stephen, Jim, Patrick. Maybe we start, Patrick, back with you, and then go Stephen, and then Jim, if you'd close us out.
Yeah, I'd say final thoughts, just use these ROI measurements to help inform your tactics that support your strategy, but you need a much broader measurement approach to truly evaluate and determine what the value of your various programs are. And that's going to be peer-to-peer comparisons. There's just, the system's too complex. There's too many external variables to take these ROI measurements to the bank, but that doesn't mean they don't provide you with useful information for decision making.
Excellent. Stephen?
And again, I would just echo what we said about, yes, you want to look for the best interventions, but also invest in the prevention. Both of them may be harder to measure ROI in the short term, but if combined together, will likely give you better value both in the short and the long term.
Thanks. Jim?
I'll just echo the comments of Patrick and Stephen. I think the cultural aspect that we've talked about is really important, looking at the friction that exists today. And you really have to look at, you know, what do you expect people to do? What do they want to do? But what's in their way? And remove those barriers, or help them get past those barriers. And then I'll come back to something that Patrick said, because I think as the provider community is now ready and looking for new financial deals, employers need to look at those. And I grew up, my first role in healthcare was in a staff model HMO capitated arrangement. And I think to this day, it was good medicine. It was holistic care of the patient, Nate, similar to how you described your relationship with your primary. And I think there's opportunities there that employers need to be pushing on.
Jim, I so agree with you. And as long as that relationship doesn't deteriorate, the financial pressures doesn't deteriorate, those models can be very effective, you know, especially if they can offer that high patient experience. Well, look, I appreciate every single one of you guys for jumping on and speaking. For those that are watching, Patrick's at Optum Actuary, hit us up. We'll give you his email. Jim's at Alliant, hit us up. We'll make sure you have his email. Of course, you guys can find him on LinkedIn. And Stephen and I are both at Crossover. Happy to continue this dialogue with others as we try to figure it out together. But thanks so much for joining, and we look forward to seeing you the next time. Take care.